Shutterstock Music.
I will, as usual, start with a prayer. The topic for this evening can flabbergast both obstetricians as well as physicians. And therefore, when Madam suggested to me that, sir, can you come down for this? I immediately said, yes, I will. Because it really tests us. And therefore, MTP in medical disorders in pregnancy, I have seen physicians, their faces falling when their patients announce that they are pregnant and when they are treating for some medical condition. Friends, the recording of this session will be available very soon on YouTube channel of mine, and I will inform you as soon as it is uploaded, and you can mail your queries to me at any time, because it is possible that after this lecture we may not have much time for discussion. In that case, this is my email ID, and I will be repeating the address during the talk. Again, there will be a bottom line there which you are able to see. I have always felt that medical disorders in pregnancy, MTP has two aspects. And like this wrote, there are 2 points to that. One is, those disorders where continuing this pregnancy would prove a grave risk to the life of the mother. Then the medical disorder itself becomes an indication for MTP. I will be coming down to these specific situations. And another, where MTP has to be done and a medical disorder is found incidentally, then the extra care that is required to be taken, especially due to this disorder in terminating the pregnancy, is what flabbergasts you. And that is where this situation comes. Let me describe the situation, then I will come to the solution. Mrs. A is a typical clinical situation. A 23 years young primigravida at 20 weeks of pregnancy presents with imminent eclampsia, 3 urea, and anasarca. Her fundoscopy shows papillary. Your team with you decide to terminate this pregnancy in the interest of the mother. Now, how to handle this? Okay, on one side there is imminent eclampsia. On one side there is severe hypertension. And you are going to cause another one more stress to her. You saw the problem. Now let us discuss the solution. This area in obstetrics is admittedly where the clinician faces a big dilemma. In clinical situations where blood pressure of a woman is rising and ominous complications are imminent or already developing in spite of a rational and correct treatment, termination of pregnancy is considered. Let us accept it that we do consider, once everything has failed and things are deteriorating, let us terminate. And a very special villain is there in this. And this villain is preeclampsia remote from term. I have spent 30 plus years in research in this. And I love this because it can be a very, very mischievous, very stormy sort of a medical disorder. It is acknowledged as a distinct entity with a strong immunological basis. In absence of any signs of abetting and development of complications, all of us have decided to terminate pregnancies in this. However, this stage usually comes in second trimester. These are not first trimester terminations. In this immunological problem, even eclampsia can occur. Though it is not very common, but it can occur. By the time they say that eclampsia occurs, kidneys are knocked off or your eyes are knocked off. So before that, you terminate. MTP is almost always considered if there is eclampsia. Second trimester termination, you do it, you know it, prostaglandins or whatever. We are not discussing the methods at all, only the medical disorder, because they are not relevant to this lecture and you know them. Now another aspect of it, where incidentally you find, say like this, Mrs. B is having early pregnancy and solicits an MTP on some legally approved grounds. She is about 10 weeks pregnant and needs a surgical termination. She is found to be hypertensive on pre-procedural checkup by you. Now, how to handle this medical condition? Incidental hypertensive, as hypertension worsens with increasing age, it is advisable to continue this pregnancy if reasons for MTP are not compelling. If you diagnose it, tell her to continue the pregnancy, please. Don't terminate the pregnancy. In spite of all of these attempts of yours, if MTP has to be done, then blood pressure has to be taken in control before you do an MTP. With suitable antihypertensive, you can bring in your physician friend, that goes without saying. It may necessitate postponing the procedure by a few days. Within a few days, it will come in control. So postpone it, control the blood pressure, then take her up. Once this is achieved, first trimester MTP under short general anesthesia can be safely carried out. It is safe. A well-controlled blood pressure, remember this, a well-controlled blood pressure does not go haywire during the procedure or even post-operative. Most physicians advise that the morning dose of antihypertensive must be taken, albeit with a small sip of water. But that depends on the timing when you carry out your OTs. My planned OTs are always in the afternoon. Therefore, with one small sip of water, she takes antihypertensive of the morning, nothing else. In cases where blood pressure goes alarmingly high post-operatively, suppose it goes, then sublingual dose of nifedipine will help you and becomes a very good treatment. So this is regarding hypertension. We put it out. Now see this picture. A typical scene in a postgraduate Viva exam. Why am I bringing it here? Because I love to watch faces of examiners. I mean, they make me laugh. I don't know why, but always, therefore I have taken very few exams. And I always felt that, please pardon me, my best friends have been examiners. Examiners are greatest fools on this earth. They can only ask you standard questions to which there are standard answers. Therefore, I have given lots of exams but taken very few. Now, these are typical postgraduate scenes. See how serious they are looking, but none of them are actually serious. A typical scene in postgraduate OG exam hall, where examiner consistently gets lured to asking this repeated question ad nauseum. What is the absolute indication of MTP in cardiovascular conditions in pregnancy? And he gets an ecstatic feeling when he asks that question. We all know this. A patent ductus arteriosus, a coaptation of the aorta is the absolute indication. We all know this. This is a standard question. But he gets so happy when the question is answered. Average clinician, however, like you and me, may hardly see such a case in his or her career. Honestly, I have seen only one case, and that was also advanced pregnancy. There was no question of termination. This is not to undermine the danger of coaptation. It can produce a dissection, and in some cases, even spontaneous rupture is known. Therefore, yes. But there is some other condition, cardiovascular, where you encounter it much more frequently. And like this, there is the valve is leaking here. And that is, I have experienced it so often, and so also you. Our physician friends, who when they diagnose a valvular heart disease in a subject, immediately get rattled when the subject tells, sir, I am also pregnant. Oh God, I have seen their faces. Many a times they have this first reflex. Consider termination. This additional load will kill you. I have seen it. Not all do it. Some of them are very brilliant. Most of them are very brilliant. But some of them do this. Now, what stand should you take if you get such a reference? On most occasions, obstetricians have correctly refused such terminations. Therefore, the bottom line in valvular heart disease is to be per se, this is not an indication for termination of pregnancy. In fact, MTP can prove to be more stressful and decompensating for the mother than a full-term childbirth. Please understand this. A full-term childbirth, though the pregnancy is advanced, will be less stressful than an abortion, than an MTP in valvular heart diseases. Please remember this. And there are reasons thereof. There are dynamic states in cardiovascular system as they approach at the labor, and that we will not discuss here. But just remember this message. that MTP is more dangerous than a full-term labor, and statistically also proved with evidence. But there is one situation where you can ask me, what about this, sir? Valvular disease in incorrigible cardiac failure. The load is so much. Now, in these situations, don't be afraid. These are rare. With advancing pregnancy and in spite of correct treatment, cardiac failure fails to correct itself. Now what to do? Some authorities are advocating that added stress of pregnancy will worsen the cardiac condition and can even prove fatal. Keeping the risk of anesthesia in mind, many workers suggest, and I have terminated such pregnancies in a paracervical block. We can do a paracervical block with the anesthetist standby. It is very difficult to make a broad policy statement in this situation. They will not be very common in modern medicine. So the best policy would be to individualize such cases and handle them with due caution. This is not a gossip, but some information which you get incidental. I will give you the situation. Mrs. C has a 1-year child and the family is migrating to Canada. You must be aware of it that amongst the 2 states, Gujarat is one state where there is maximum illegal migration taking place. We are at the top at many things, but unluckily this is not some good thing which is happening. But then this is a fact. But then she walks into your clinic, she is migrating, legal or illegal, none of your business. Before leaving, she visits you as she has overshot her period and thinks that stress of migration, travel, etc. must have done this. But you being a smart doctor, as per your routine, do a urinary pregnancy test and find her pregnant. This is incidental. Now, it is your routine, as any good clinician would do, to do a CVS RS auscultation, and you find that there is a typical mitral stenosis murmur, diastolic with presystolic accentuation. We all know this. This is the murmur. She insists on termination. Now what to do? Sir, I don't want to go to Canada with this. As such, I am in severe stress. On most instances, these are valvular heart disease. Remember, it is advisable to continue the pregnancy. Come what may, please continue. Risks of termination require to be explained in case of MTP becomes a must. A thorough cardiorespiratory assessment will help in foreseeing problems that may develop in due course. Well controlled, you can do it. A rational antibiotic umbrella must be given to the patient so that she doesn't develop endocarditis. This is simple, but has to be put into practice. The other condition, which we all know, but I want to discuss it, and that is diabetes. Diabetes in pregnancy. Since 1971, you just see the pictures. I invite people like Dr. Manpreet and Dr. Rajesh to see pictures of before 1970, general pictures of human beings. They are all lean and thin. And after 1971, you see what has happened. Obesity has become a global pandemic. Even we are seeing they are starting pregnancies at 108. Last year, end of last year, 108, she started her pregnancy. We treated her infertility. 108, and by the time her pregnancy ended, it was 126 kilograms was her weight. Many reasons have contributed to this. I don't want to, this is not a lecture on obesity in pregnancy, but it has also brought diabetes along with it. Besides many other friends, it brings this obesity. How good is diabetes mellitus with obesity a reason to terminate a pregnancy? I am sure reflexively every obstetrician is going to do this. No, per se diabetes is no indication of terminating pregnancy. Poorly controlled diabetes leading to major congenital malformation in the baby, which is incompatible with life, then it is a valid indication for termination of pregnancy. Lest, no. Another situation, incidentally found diabetic. I am coming to how to handle it. This is handled by proper adjustment of doses of antidiabetics. MTP is not the solution to the problem, but if you have to carry out, then Like cardiac disease, many times obstetricians do get references from physician friends soliciting MTP for diabetic mother. Most of the times, obstetricians say no, and this is admittedly a wise policy. It need not be overstressed that such patients should be counseled for continuing. Fine. This is because diabetes is known to worsen with increasing age. Why are you escaping? If you want a pregnancy later on, this is the pregnancy. And good control is now easily possible. With insulin and even oral anti-diabetics, excellent control. Last month, I had 4 diabetics hypertensive delivering at my hospital. 4 of them. All excellently controlled, all excellent outcome. And therefore, no need. However, needless to add, proper control of diabetics should be instituted now in these subjects. But sometimes we don't have a choice. We have to terminate. What is to be done? A preoperative excellent control of diabetes has to be achieved. Now, these are some of the points, please remember. Proper maintenance of euglycemic state on the day of the procedure. With the automatic machines, it is very much possible. It is advisable to have a subject a little towards hyperglycemic side. Please remember this. Give them a little hyperglycemic because hypoglycemia can go undetected and can prove dangerous. A little towards the higher side is acceptable. 144, 148, 150, fine, don't be alarmed. But 80 can immediately drop to 60 and that can be dangerous. Post-operatively, the woman has a higher chance of, remember this, post-operatively, the woman has a higher chance of going in hypoglycemia because around 20 weeks it has already exerted its effect. Diabetic or pregnancy is a diabetogenic state. You have removed the pregnancy, immediately precipitately falls. This is because, also the second thing, this is because, and practical thing, this is because the time that has elapsed from her taking meals the previous night to that at present when she is rendered hypoglycemic is increasing. This is not her normal time of consuming meals. So she will become hypoglycemic. It is advisable in such cases, without fear, to supplement parenteral glucose adequately in such conditions if needed. But be aware of hypoglycemia. Be afraid of, just as it is said, that even in hydration, overhydration kills. Underhydration doesn't kill much. Overhydration is bad. Immediately the lungs give way. Blood glucose estimation is now more precise. Susceptibility to infection, you all know, therefore a good cover of antibiotics. Now this situation, anemia. Anemia you want to terminate? But yes, one of the most common medical disorder for which MTP is solicited in medical disorders in pregnancy statistically is non-nutritional anemia. I'm not talking of nutritional anemia, non-nutritional anemia. And you are handling it. These are like thalassemias. When both partners have tested positive for thal trait and the fetus is affected by thal disease. You all know this excellently. NIPT, utilizing the now doing ddPCR assays, CVB or chondrosynthesis for detecting thalassemia in the unborn fetus is very well known. I'm not going to give a lecture on that. This lecture is not on that. Subjects testing positive for thalassemia in both partners will solicit a termination most of the time. One side is the need for termination, other side is low hemoglobin status. Now, how to handle this? You would like to ask. A pregnancy in which the fetus is affected by thalassemia, you also will consider a termination. This also holds true in parents with sickle cell disease at times and the baby is affected. MTP after proper counseling may be required. Those mothers who are invariably thalassemia minors may be having anemia and you are going to terminate her pregnancy and she is teetering around 8 grams. 8 grams, it may be even less. And you have to terminate the pregnancy and usually these are second trimester pregnancies. Now what to do? In such a situation, a proper oxygenation, intensive monitoring of SpO2 and other vital parameters and prevention of cardiac overload is going to be a big challenge. Excellent intensivists may be required. Don't be afraid. You can shift to intensivists where if you don't have an ICU, but you can go there and terminate the pregnancy. Don't worry. But then anesthetists are excellent in managing these situations. Post-operatively, usually these subjects remain stable. Usually they are stable. But because this is a larger pregnancy, second trimester MTP in subject is done with usual method that I am not discussing. But excessive blood loss after the abortion should be actively prevented because she is already in minus and her low oxygenation in her tissues will immediately precipitate a failure. So very much more readily than what it may precipitate in you and me. So be on guard. If it still occurs, if a failure, if a bleeding occurs, obstetrician has to manage it very actively and treat it enthusiastically. However, her chances of bleeding are the same as in general population, so don't be afraid. She is not going to bleed because she is thalassemic. No, chances are same, but she will respond badly. So don't let her bleed and move very fast. Other situation is when a pregnant lady solicits MTP for some valid reason under the law and incidentally found to be anemic. What should we do in such situation? Subjects who solicit MTP for other indications and are found anemic are usually advised to wait till their anemia is corrected. Such a policy is wise and should be recommended. Treat her anemia and then terminate her pregnancy for whatever reason whatsoever. Let not your being judgmental about MTPs come into play here. We are discussing, or the topic I have been clearly given is termination. And if you have to terminate, then wait, correct her anemia, and then. And even in the thalassemic patient, bring it to 8 if required by giving blood and then terminate. Till then, don't. If it goes beyond 8, sometimes it touches 9, fine, but hardly crosses 10. Hardly crosses 10. In such a situation, blood grouped and cross-matched be kept ready when you terminate that pregnancy. If she bleeds, she will not tolerate the blood loss as well as a non-anemic patient. My physician friends have shown me this face many times. They are very scared. I remember when we were still doing PG and into few years of my assistant professorship, our physician friends used to jump as soon as they got pregnant with a pregnant patient with jaundice. Please terminate the pregnancy was their consistent request. I remember this. In cases we sought a transfer of a pregnant subject who got incidentally admitted with us and had jaundice, but not in labor or abortion process, and we sent them a reference that this is nothing obstetrics in there, they would try to run away. You send her after terminating pregnancy, till then we will not accept. How accurate was this response? I wonder. Well, we all know the answer that this is most misunderstood. This condition also and this response is not acceptable. Probably nowhere has the role of pregnancy termination been poorly understood by our colleagues in internal medicine than in jaundice. There, an assistant professor consultant's wife had hepatitis and they transferred her to the labor room and I got her in charge. I was also a consultant. Why they had sent her there? A physician said that terminate pregnancy, then only we will be able to treat. I had to request them, this is your colleague's wife. Why are you doing this to her? In modern obstetrics, there is no role of MTP for jaundice in pregnancy, especially I am talking of hepatitis. In fact, MTP can worsen the maternal condition and can take her to complications much more speedily. So please don't hasten it. Usually hepatitis is a cause of jaundice. If there is a non-hepatitis cause, then you have to individualize the case. This is known to worsen consistently. It is also true that mothers so suffering are very likely to develop complications like post-procedural bleeding, which can even prove fatal. It is therefore recommended not to terminate. However, on nature taking its own course of terminating the pregnancy, which happens many a times in hepatitis, severe hepatitis or hepatic pre-coma, if nature aborts it, then it should be managed as such. No obstetrician will ever do an MTP, even if it is incidentally found. Such a decision is commendable and appreciated. asthmatic pregnant mother. I have got these references, therefore I am bringing this situation. For many of you, you are all very smart people. It must be laughable, but they do come. There used to be a running joke when we were residents, and our classmates and friends used to be second year or third year residents in medicine and surgery and orthopedics. And in the evening, once the bosses had all gone, teaching was all over, we used to get together in the canteen or somewhere to have a cup of tea in the hospital campus. And that is where there used to be a running joke. You are not terminating jaundice patient's pregnancy. What are you going to terminate bronchial asthma? Isn't it, Pankaj? And they used to try to put me in corner. Why don't you accept, Pankaj, that the load on her vital respiratory system would be less if you would terminate her pregnancy? Used to be their very enticing argument. In the early days when I was a second year resident, not yet well read, I used to do like this, wondering whether they are talking right. But then I know none of the respiratory diseases are an indication of MTP in modern obstetrics. However, those using prostaglandins for routine MTP are advised to rule out bronchial asthma, and you know this before the procedure. Anesthesia risk in women having respiratory problems is well known. Besides a good, if you have to terminate, then from the medical disorder point of view, a good preoperative control, a vigilant intraoperative monitoring is both vital. It is not advisable to take up mothers for MTP in presence of active respiratory infection. Control it with antibiotics. Make her stable. Treatment is usually very effective, and postponement, if at all, will be for a few days, and you will be able to terminate the after. And let us see one more such disorder, a common one nowadays, and that is thyroid disorders in pregnancy. Maternal hypothyroidism is relatively common now and may be diagnosed, but there are times when not be diagnosed and therefore not treated during pregnancy. If such a subject comes to you soliciting an MTP because she was diagnosed late or she was not treated in time before the pregnancy started, what stand should we take? Currently, it seems unclear as to how detrimental that situation is going to be for the developing neonate. And why this is so is because data is not enough. I am going to fall back upon this repeatedly because I feel thyroid conditions or hypothyroidism is a very tricky situation as regards MTP is concerned. And there is a big ethical dilemma. What is ethical and what is unethical? Let us see. It puts every practitioner in this dilemma. It is a debatable issue as to whether clinicians should recommend terminating a pregnancy when severe hypothyroidism is diagnosed late in gestation. And the subject will leave on you, as it happens so often in our clinical practice. Sir, ma'am, what will you do? Well, in such a situation, we don't have enough data, so we fall back upon the available consensus. And the consensus, usually in medical science, are quite scientific, quite sensible. And what is the present consensus as regards maternal hypothyroidism is concerned? It is against recommending an abortion. As of now, if in such a situation or such a patient comes to you, we will not recommend an abortion on our own. There are situations where we recommend an abortion, but not here. But despite the administration of thyroxine, future parents, we will not be able to reassure about the potential brain damage as a result of long-standing and severe intrauterine undiagnosed hypothyroidism. Because we don't have enough data on this. And let me assure you, keeping in view of the nature of this condition, it seems highly unlikely that any randomized clinical trial will ever be done to assess at what cutoff TSH level should MTP be advised? If this is the level of TSH, then you have to undergo an MTP. No, no such data is available, no such data is going to be available. In such a situation, follow the consensus. Also, it is very important, I am aware of it, that decision making will vary from region to region, depending on the level of the iodine intake and the frequency and severity of overt hypothyroidism in pregnancy. Also, it will vary between clinicians and clinicians based on their personal clinical experience. I accept it. It will also vary from patient to patient based on their personal attitudes, beliefs, and practices regarding abortion. And we accept it. Often, the decision may be taken because of non-endocrine issue and other obstetric-related factors, with overt hypothyroidism being just an incidental factor favoring an MTP. We have seen this often during this lecture as to where the medical disorder is identified by chance, incidentally. What should we do? The rule of thumb, therefore, is to dissuade the subject from MTP and explaining, however, at the same time about lack of quality evidence to take a clear scientific stand. And whenever such an amorphous picture is happening in our clinical practice, and it happens quite often, we individualize the case. We individualize the case. So that is how thyroid disorders in pregnancy are handled. Friends, this subject, you will accept, has a big gamut, a big scope. Medical disorders in pregnancy in itself is a thick book which we read, or which we used to read when we were doing post-graduation. It is impossible to cover each and every medical disorder in this lecture. I have to try to cover as many as possible, especially the main ones which are affecting our clinical practice, so that the clinician and students of subject are reasonably confident and scientific in reaching a decision. For relatively common conditions, you will have to fall back upon references, or you may please contact me without any hesitation on my email, and I will surely reply. That is my promise, and I will guide you to the best of my ability. My email has been displayed here, drpankajadesai@gmail.com. I have made you run through nearly the entire gamut of problems of day-to-day clinical problems. I am not covering the rare problems, because when you think of rare things, you are rarely correct. And second thing is that being a teacher, I know for clinicians it is very important to be practical. This lecture is aimed at what you will routinely require to do. Any mother who is pregnant can have a medical disorder in pregnancy, and such a mother can also solicit an MTP. Wisdom lies in correctly understanding the disease, its problems, its behavior. As I told you, any mother can be pregnant, can have a medical disorder. If for flimsy grounds that they walk into for termination, don't terminate if there is a medical disorder. And if you have to, please control the condition. Most of the times they come in control within days. And once you understand the disease, decision making for MTP is not difficult. You decide as per what I have told, what books mention, what references tell. So friends, I know it's a drab topic. It's a mundane situation. Most of you know the answers, but it tests you when you get cornered. And when it comes, you surely get cornered. And therefore, the aim of this lecture was to fire you up. To fire you up. So many things will be revised, but regularly you require to revise. I am sure there are new things, and I have put in the references right up to what I have not shown you the source, but they have gone up to 2023 June. And so that you can skillfully handle it, you will have to be well informed, well read, well observant. That patient, how did she behave? Or somebody was very observant and well prepared. Then to handle medical disorders, termination is not difficult. And then you will have every reason to go successfully towards scientific excellence at the service of humanity and mankind. Thank you, Dr. Shankar. Thank you, all the chairpersons. And thank you, Kasuga. May God bless you. May God bless you.